Welcome back to Clinical Communication. This episode, I'm delighted to be joined by Nick Livadas, who is an advanced physiotherapy practitioner and clinical lead at Connect Health, as well as being the lead for the Musculoskeletal Injection Therapy module at Teeside University. In this episode, we discuss communication around Nick's special interest, which is steroid injections for musculoskeletal pain. We discuss how to set expectations with steroid injections, how to discuss the risks, and how to advise someone when a steroid injection may not be in their best interest. If you find this useful, please do go and share it with others. Please do subscribe. You can find Nick on X or LinkedIn. You can find me across social media at BYbrowPhysio. Thank you for listening or watching, and I hope you enjoy it.
Might not make the threshold for nice approval, but yeah, time will tell.
Nick, thank you very much for doing this, first of all, and for giving up your time on this Wednesday evening to speak to me and everyone else listening, by the way. I've already done your introduction at the beginning of this. And we should be clear for people listening now, we're talking about the communication with steroid injections. Nick has other resources and of course, which we'll come on to about the reasoning with them. Before we jump into all the specifics, Nick, what was it about steroid injections that got you so intrigued in it and became your specialist topic?
Yeah, it was by accident, to be honest, Ben. I graduated in 2004 and 2008. I did the injection course, so quite early on in my career, and that was with Southampton University with a tutor called Tony Wilson. He used to do great shoulder courses and patellofemoral courses. I don't think he does the course scene now, but that early foundation course got me interested in steroid injections, and I was on a path at the time for advanced practice. Around about the time when MSK interface services came along, and having the skills to perform steroid injections at the time was seen to be a necessity of advanced practice. And thankfully, advanced practice has changed over the years to be more than just the biomedical kind of interventions that you offer. So, like any new skill at the time, I probably injected a lot more patients than maybe I should have done. Probably a lot more patients than I would inject now. And I think that happens with new skills, with everyone. You get that kind of excitement around it. And then over the years, I continued using it as part of my practice, both privately and in the NHS community services. And then about 5 years ago, I took on an academic role at Teeside University, and I noted that there was no foundation injection course in the north of England, above Bradford and maybe central Lancashire. So I went about setting up a 20 master's level module in injection therapy, and it was my baby. I developed the module and still teach on the module, and it's a great module that really kind of got me into the research around injections and made it clear that actually there's so much that we don't know around injection therapy, despite it being used for over 70 years.
70
You know,
years.
yeah, steroid
Wow.
injections have been used for over 70 years. And in that time, the practice hasn't really changed that much. And the practice hasn't changed in part because the research hasn't been there to give us the answers to change our practice. And where there is evidence that suggests certain aspects, that doesn't seem to have percolated into any changes in practice. So it was really quite intriguing, which is why that then prompted me to do, well, let's run an update course. So then I developed an update course, which is an online course for injectors and non-injectors that just aims to ask those difficult questions, challenge the status quo, and bring some of the evidence into clinicians' minds a little bit more at the forefront to try and develop our practice around injection therapy that bit further.
And I need to give full disclosure now that I've never injected someone. I have plenty of colleagues that do, but I've never myself ever put the needle in someone. But you obviously have and trained others as well. What do patients classically ask about steroid injections when you're discussing it with them?
Yeah, and that's a really important question because I think as clinicians, we need to pause when we're considering a discussion around injection therapy. Either they're asking for it or we think it's an option. That we ask what they know about injections because they might know quite a lot.
Yeah.
And you might not need to go into certain areas that you thought you would need to go into, but they might know very little. Or they might think they know something that is quite far away from the truth. There are
Ah,
lot of kind of myths around injections as well. So by asking a patient, what is it you know about injections? Have you had them before? Do you know anyone who's had them? Sometimes you get that glimpse of where they are on that scale of either really wanting one or really thinking, I think I might want one, but I'm not sure, in how they respond. Um, so that's a useful question. And then from there, it's useful then to ask, is there anything particularly that you'd like to know about injections before we, verbally vomit everything we know about injections on them?
yeah, yeah.
It's better to tailor it and target it to what they want to know. And quite often, from experience, the number one thing patients want to know is, does it hurt?
Really?
Yeah, does it hurt is the number one. There seems to be this public perception that they're really painful, and someone comes with this kind of 10-inch long needle,
Yeah.
um, and the evidence suggests it's around about a 4 out of 10 pain. And that's usually how I kind of respond. On a pain scale, 0, no pain, 10 being, excruciating, it's about 4 out of 10.
Okay.
And usually patients then go, oh, that's not so bad then. So that kind of allays the fears a little bit about it. Sometimes there's kind of, I say, what do you know about it? Oh, it goes in the bone, doesn't it? And that always takes me back as well in that, where do people get the idea that steroid injections are put into people's bones,
Yeah.
through the cortex of the bone and shoved in? I mean,
Yeah.
that sounds painful to anyone,
Yeah.
So maybe that perception of why this is painful is linked to the public's belief that they're going in a bone. And
Mm.
there was a study in South Korea a few years ago now, and Saudi Arabia just last year,
Right.
that surveyed people's views about injections. And this was a common theme, that patients thought it went into bone, it dissolved bone, it made you put on weight. All of these kind of negative connotations around steroid injections. And it's a study I'd love to repeat in the UK, just to see how far we are different from South Korea and Saudi
Yeah.
Arabia. It might be very different, it might not. Um, but that's the number one question I hear is, will it hurt? And
Mm.
how I tend to kind of, allay their fears around that.
Are there any other misconceptions classically?
Um, for some people, it's that it can be curative.
Okay.
And that's a really tricky one. But we usually get to that point by asking them a question, such as, did you have any thoughts as to how long the injection might be effective for?
Mm.
And their answer gives you your response immediately. In that, if they look a bit blank, as if to say, well, it's a cure, isn't it? Then it gives you that indication that they're thinking this is going to be curative, which then kind of opens a door at that point for you to say, well, we know from these injections that they can be useful in some people, not everyone. And
Mm.
that's really important to say, that they're not going to work for everyone. But they are typically short term in how long they last. Very rarely do people tell us that they resolve their symptoms.
Mm.
And pause. Let that kind of filter and let it percolate, and let them bring the next question, which is usually, so how long do you think it'll last for? And then if we look to the evidence at that point, such as for OA knees, osteoarthritis, we've got the NICE guidance. And within the NICE guidance, it says specifically now between 2 weeks and 10 weeks.
2 to 10
So
weeks.
2 to 10 weeks.
Mm.
And within the NICE option grid, which is a nice option I use in clinic, and certainly something I'd recommend for injectors to help that communication, there's a little printout section of that I've got laminated, and it's got a little kind of sliding bar of 0 to 100. And it tells you how many people out of 100 would benefit from that intervention. And they've got one for injections.
Okay.
So I'll get that out with a patient, say, and let me share this with you. Tell us a little bit more about injections, so they can visually see it as well as hear it. And the sliding bar shows that an injection for their arthritic knee will help 50 people out of 100. And then we'll go on to add, and for those that it does work with, it will typically last between 2 weeks and 10 weeks. What the next question I pose, it's probably really important, is how do you feel about that?
Mm.
And pause. Just hold the silence for a few moments and let the patient kind of look back at the, option grid in front of them, filter in the effectiveness rate and the duration of effect. And usually, Ben, that that's often a lot less than people imagine. And then quite often, sometimes the response is, well, that's not very long, is it? That's not good odds.
Mm.
And sometimes they'll say that flippantly and say, oh, it's not very good odds, is it? Um,
Yeah.
and other times they'll be that they won't seem too moved by that. It doesn't seem to kind of shift their mindset if it's something they really want.
Yeah.
But it will vary by patient. But using those option grids and some statistics where we can to that question of how long will it last, I think is a really important part of the communication process.
Well, that does that influence how many then say yes? Once you get out that your shared decision making sheet and show
Yeah,
them the 2 to 10 weeks,
yeah.
do you find do more drop out or say yes compared to what you'd expect?
They really do. And they really do. And I've got a similar sheet for subacromial injections as well. And that was produced by Jeremy Lewis. It's a great sheet. Again, you can laminate it, take it in clinic, and use it as part of your consultation. And those kind of sheets and option grids are great for people with low health literacy as well.
Mm.
Something visual as well as verbal to kind of take in the information. And for those patients that come thinking that's the only thing they want, maybe they haven't tried any other conservative measures,
Yeah.
it's a real way to kind of open the door to say, well, there are some other options if you'd like to discuss them.
Yeah.
Okay. And then we discuss the lifestyle changes, the exercise, the physical activity, the sleep hygiene, and all the other factors related to pain
Yeah.
that are probably going to have more influence
Yeah.
in the bigger picture.
Yeah.
And for those people that are maybe a little bit unsure whether it's for them, it it usually is enough information to say, okay, that's maybe not for me. But then there are other instances when I think an injection is the best thing for the person, despite the odds not
Yeah.
being great.
Yeah.
Things like trigger fingers,
Yeah.
carpal tunnel, OA of the big toe or the thumb joint, where there's not much else from a physio perspective we can offer that's going to be very effective. So I might kind of present the information in a way for those kind of patients that maybe is a little bit more inviting
Mm.
for them to consider the injection. So it's how you kind of sell it. But I think we don't want to demonize injections because for some people they're a really essential and important part of management. But at the same time, for those people that intuitively we think it's not the right thing for them right now, with a careful and sensitive communication of the likely benefit, the duration of the benefit, and then maybe some of the risks, we see those patients often quite easily come round to the idea that it's not for them.
Yeah. Out of interest, comparing when you started doing them in 2008 and a few years after that
Yeah.
to now, in the past few years, have you noticed a change in what patients either know or want to know compared to when you were doing it those years ago?
I think so, Ben. I think patients are more informed nowadays. In 2008, we probably had Nokia phones.
Yeah.
The internet wasn't great. If you did
Yeah.
have a phone, maybe you had a BlackBerry, so you had a bit of internet, but it wasn't great. But now everyone's got the whole world's worth of information in the palm of their hand.
Yeah.
So if they think they need and want an injection, chances are they've Googled it.
Yeah.
And of course, there's so many unreliable sources of information. Um, Many maybe suggesting that they are curative. They are an essential component to managing care. So that can be a challenge. And I think that is the big difference. And I think that the dial in terms of paternalistic and consumerist medicine has probably shifted towards consumerist. So people, the public, are generally more expecting of certain interventions than maybe they were 15 years ago.
Mm, fine. Now we talk about expectations and setting them. You said about your shared decision making. We were talking about this before we started recording, and it's a phrase that you mentioned and is mentioned in my service by various colleagues. And people talk about with injections a window of
Yeah.
opportunity. Uh, is that still a suitable phrase? in 2024. What do you make of it?
It is still used. It's still used in physio, in MSK around the use of injections. And it's often when patients are not progressing well with an exercise rehab approach because it's too painful.
Mm.
And pharmacological measures, both oral and topical, haven't alleviated that level of pain to a degree that they can do their exercises. So often the next step is, well, exercise is vital, right? So you need an injection to lower your pain to allow you to do exercises, packaged in a way that the injection will be short term,
Yeah.
which is a good thing, but then gives the patient that hope that this will lower my pain, take it away completely. I'll do all my exercises and all the things I've been told to do by my physio,
Mm.
and a combination of those two will mean I'll be on a path to recovery.
Yeah.
And it's just a bit too simplistic, I think. But
Yeah.
and I'm not sure that if we are lucky enough to get that window of opportunity, i.e., pain relief for 6, 8 weeks, patients then have got a situation where they're no longer in pain, they're back sleeping well, they're back doing their meaningful life activities, happy days. Where's the motivation then for them to re-engage with the physio,
Mm.
do their exercises,
Yeah.
2, 3 times a day, whatever they've been prescribed, when they feel great?
Yeah.
But then the steroid wears off and the pain comes back.
Yeah.
And they might have that reflection of, oh, I didn't do my exercises when the pain was better. So I think sometimes we have the situation where we create a window of opportunity, the window is
Mm.
open, but the person doesn't go through. So
Yeah.
maybe that's our fault. Maybe that's the clinician's fault for not kind of, working on that behavioral change aspect, using our behavioral change skills, our communication skills to support the patient on that journey.
Mm.
Maybe the lack of follow-up on behalf of the injector is to blame. Maybe the lack of kind of seamless care from the injector to the physio
Yeah.
is to blame. So it would be remiss to put that on the patient, because it would be a natural thing of, I feel better, things are great, why would I do my exercises now?
Yeah. Yeah.
And partly maybe it's on us to make sure we, you know, align the care pathway so that patients do engage in the rehab afterwards, and we can help them kind of work through that.
And of course, that's great when the window opens in theory, and obviously when they get relief, as you said, and I see it as well. As you said, 50% for a certain situation, not everyone. And I have to have the same conversations with our patients and say, look, yeah, and they've come away from this conversation with the usually doctor or person who's going to inject, and whether they've got the impression that it will help. And we have to say, look, actually, it won't help everyone, and there is a chance that it won't. Um, is there a way you found about telling them, weighing up the won't help, might not help bit to make it more, yeah, easier for them to acknowledge?
So I guess it's kind of framing it that, like any treatment, it might not work.
Yeah,
And a nice analogy I use is that, if you take this is a medicine, what we've got to inject here.
yeah,
It's an anti-inflammatory medicine. And most people in the public know that term. They take ibuprofen, they know that's anti-inflammatory. So then I'll say something like any medicine, a medicine that you take in tablet form, it wears off.
yeah,
Yeah, usually after about 4 hours. The medicine in this injection is longer lasting, but like any medicine, it's going to wear off.
yeah,
And that sometimes helps patients kind of link that. Yeah, I get that tablets wear off. Okay, I guess this is a medicine as well. Oh, yeah, so I guess this is going to wear off as well.
yeah,
So that kind of sometimes helps patients understand that, yeah, it is going to be short term,
yeah,
and there might be kind of more I need to do on my side to kind of get the longer lasting benefits.
yeah. Well, and on the flip side of that, there are people it doesn't help, and you may have seen it. I've certainly seen it. Very occasionally, you have that person who has the injection. You're expecting the short-term relief and for it to wear off, whatever reason, the benefit lasts a lot longer, months, maybe years potentially.
Yeah.
And they
Yeah.
leave and they don't come back to the service. And then you have the conversation and they say, well, it lasted a year last time, or it lasted 6 months. If they say why or how, what should we say in that situation?
Yeah. It's a tricky one. And a lot of patients I find around tennis elbow,
Mm,
they had tennis elbow 5 years ago. They'd seen the GP. After having it for months on end, the GP injected it and it went away
yeah,
and got the same on the other side.
yeah,
They just want an injection.
mm,
They don't want to try anything else because it just resolved it last time. And equally, some people say, well, you know, Barbara down the road, she had her knee injected. It's been fine since. That was 2 years ago. So sometimes people have these stories that they can relate to and bring that conversation that almost flies in the face of it being a short-term drug that will wear off.
yeah,
Pharmacologically, we know it's a drug that wears, it stays in the joints about 3 to 7 days, 3 to 7 days. It stays within the kind of systemic system no more than 3 weeks. So we've got a situation where, with most injections that last 6 to 8 weeks, there doesn't appear to be a rational scientific explanation why it does last that length of time,
yeah,
and certainly not months or years on end.
yeah,
So there are some theories out there around why ineffective treatments work. Um, Maybe it's regression to the mean.
mm,
People with osteoarthritis find things go up and down over time. So maybe it was people seek care when it's at its worst. So whatever care you provide is probably going to mean it regresses to the mean that then attribute to the injection.
yeah,
I guess another one is placebo.
yeah,
And there are a number of placebo, controlled trials where the placebo does equally as well as the steroid.
yeah,
We see placebo shoulder surgery now. Um, Natural history, some things just get better with time, especially soft tissue disorders. Um, and maybe the patients did jump through the window of opportunity, and maybe they did do their exercises
yeah,
afterwards. Maybe they start sleeping better. Maybe the life stresses around the time of the injection changed. So because we know pain is multifactorial, it's difficult to always pin it down to that injection. But from a patient perspective, I probably communicate that in a way that says, well, for some people, sometimes these injections do give very long-term relief, but we're not sure why.
mm,
And that is in the minority that is the case. And I think we need to be honest with patients that when we don't know why,
yeah,
let's just be honest.
yeah,
You know, we don't know why because we know the drug lasts a few weeks, but for some people, they get many months benefit.
yeah,
And be comfortable with not knowing. And
yeah,
patients probably appreciate that honesty sometimes than us trying to blag it with some pseudoscience.
And let's say you do the shared decision making, you go through it with the person, you've reasoned it would be appropriate, they're on board. Um, how should we explain the risks to them? This is still a medicine, it will come with side effects or risks. What's the best way you found to explain the risks to them?
Yeah. Some of that comes from your open question to begin with. What do you know about steroid injections? What would you like to know? And what they like to know is very rarely side effects. Patients just don't seem to want to know about that, which I always find quite intriguing.
Mm,
But as part of an informed consent process, it's so important as clinicians that we do go on that journey of explaining the side effects medical legally for nothing else. So I tend to break it down because there are a lot of side effects, and we risk just losing the patient if we just reel them off. You know, so I'll try a little bit of chunk and check. So I'll give a little bit of information, pause, and say, "What are your thoughts so far?" And they usually say, "That's okay," and then I keep going. Or they might
yeah,
say, "Oh, I didn't realize it did X,"
yeah,
and then we might kind of unpick that a little bit more because certain risks might be more relevant for some people than others.
yeah,
I tend to break it down into local side effects, i.e., side effects that might affect the area where we're going to inject.
mm,
So that might be changes in the color of your skin.
mm,
It might include a dimple where the fat wastes away slightly around the injection. It might be that it's sore afterwards for a few days, a post-injection flare. Okay. It might be that it can weaken the tendon. for a few weeks. It might be that if we repeat these over a number of times, it might accelerate the wear process in the joint.
Yeah.
So other those kind of local side effects, and then go through what do you think about that? Do you have any questions, any thoughts about that? And then we'll go through the more systemic side effects, starting with the more serious infection. I'll tend to kind of offer numbers as well. So for infection, I might say, it can be about 1 in 50,000. And that's really rare. It's a little bit like going to St. James's Park at Newcastle United and one person in the crowd getting an infection. And then people go, oh, that's fine. It's not many, is it? Big crowd. So that sometimes helps people link the numbers to, how likely that is. We'll then talk about, you could be allergic to it. It's something you've not had before. And like anything you've not had in your body, you could have a reaction to it. And then it depends on if they're diabetic. We'll tell them it might raise the sugar levels for a few days. If they're taking anticoagulants, it might make them more prone to bleed internally within the tissue or the joint, or some bruising. If they've got kind of ocular symptoms or other kind of eye symptoms, it might raise their intraocular pressure and give them some dizziness, some visual changes. So we'll kind of go through those, but bit by bit, we'll pause and just check if that makes sense. Do you have any thoughts about that? And usually finish with an open question of, how do you feel about those risks? As opposed to, do you have any questions about that?
Yeah.
Which is a yes, no. And usually indicates to a patient, you don't want them to ask any questions because you want to move on to the next point.
Yeah.
But, keeping it open in terms of, what are your thoughts about those risks? Just allows them, if there are any nagging thoughts, it's more inviting for them to say, oh, I didn't know about the changes to your skin. It's on my wrist as well. That would make it really obvious, wouldn't it? And for some people, that would be a big deal. And that would be enough for them to say, yeah, maybe it's not for me. I don't like the sound of that. Or, lowering of their immune system. Another systemic side effect. If their immune system's already low, they've got other, comorbidities, they've had a spate of infections over recent months, the patient might say, oh, I didn't realize it would lower my immune system. I've had a lot of trouble with infections recently, say for COPD, and I've had chest infections, and the like. And sometimes that's enough for them to think, okay, I didn't realize that. Maybe it's not the best option for me, But it's about presenting it in an unbiased way, ideally where we can, with some numbers to quantify the risk. And to supplement that, what's often common practice with injections is to give the patient some written material to take away, just to kind of read, ideally in a kind of a readability language that's at quite a low level so they can understand it. And then to rearrange the injection if they still want to go ahead in a few weeks' time. So they've got that time to contemplate the information, the risks, the benefits. Because there's a risk if they come to a 20-minute FCP appointment, for example, maybe an injection wasn't on their radar coming to that appointment, it's been presented as an option, the clinicians rolled the sleeves up, got the injection ready and injected, and the patient goes out the door. Question mark would be over, have they had a chance to fully understand the risks and benefits?
Yeah. So you'd always advise, have a discussion, and then they come back at a different time for it.
Yeah.
Is there a certain time you'd give it? Like you said, a few weeks, but should it be at least a week or at least a certain few days?
I think a few days would be ideal. If you work in, say, an NHS interface service, if you've got a physiotherapist that's referring to you for an opinion, a lot of the physios do a really great job at having these kind of conversations nowadays. They'll give the patient the leaflet to read beforehand. So often then patient arrives at the appointment, and in some cases they're really well prepared. They've got their questions written down. They tell you what matters to them. When you open that question, what do you know about injections? They say, oh, well, I've read the leaflet. I know it does this, 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 and this. So in that instance, it might be really appropriate to proceed, and the patient might not want to review because they're all excited maybe and expecting an injection. Some tell me they've not slept the night before because they're worried about the injection. So to then say, now think about it a bit more, have a few sleepless nights more, and come back in a week or two, might not be the best thing to do.
Mm. So if I bring you to I can only assume is one of the more difficult conversations with injections, where we have someone come in who is keen for it, who's read through the material, uh, but they may have had one in the past, it hasn't helped,
Yeah,
or they have other medical issues, and you reason that it's not going to be in their best interest or not going to be appropriate for them.
yeah.
And yet they may have come in with that expectation, hoping for one. How should injectors go about having that conversation?
That's probably the most difficult conversation a clinician that injects has, to be honest, Ben. And sometimes through gently asking them what they know about the injections, about the risks and benefits, the ideal is we get to a point where they tell you it's not the best thing for them,
Yeah.
as opposed to being that paternalistic clinician that says this isn't going to be offered to you. And in most cases, if we use our communication skills well, we can get to that point where the patient realizes themselves, yeah, this isn't the best thing for me, is it? But there will be cases where that's not the case. And you're an autonomous clinician, we've got a professional code. And if we don't think an injection is in that patient's best interests, we've got to hold ourselves true to that and
Mm.
say, in my opinion, I don't feel this is the best treatment option for you.
Yeah.
And pause. Let that land. Um, See what the patient says back to you. Often it's, well, why not? And then you might kind of, reiterate some of the things you've already done before,
Mm.
but outline some of the alternative therapies, treatments that might be more appropriate. And sometimes those alternatives might be they have to live with this, like many MSK disorders are long-term conditions.
Mm.
Um, and part of that is getting to that point of acceptance that we can support the person to live well with this condition using X, Y, and Z. And for some patients, that's not for them. They're not at that point in their thinking. Um, and that's sometimes not the fault of the clinician. It's just
Mm.
the journey that they're on.
Yeah.
Um, and that's tough to have those conversations. And working in pain services, you probably have those conversations pretty regularly.
Yeah. Yeah.
But equally, there are some times when patients are better suited to seeing an orthopedic surgeon.
Mm.
And an injection isn't the best option for them, or another injection isn't the best option for them. And you see many patients that have injections 2, 3 times a year for several years when a surgical procedure is a gold standard treatment option for them.
Yeah.
Yet no one's presented it in a way that makes it look like the best option. I've seen so many patients with carpal tunnel syndrome that have sometimes several injections over many years are coming and going. And we chat about the surgical procedure, a 15, 20-minute procedure, in and out within an hour or two,
Yeah.
usually in a community, not even in a hospital, with great outcomes. And the patient didn't realize what a great option a surgical decompression for the carpal tunnel was. And that makes that conversation really easy because they say, oh, yeah, that sounds great. That if that's more curative, I don't have to keep coming back for these injections. Why wasn't I told about that sooner?
Yeah.
And equally, knee arthroplasty, hip arthroplasty, two of the most successful and effective surgeries in orthopedics that patients sometimes need to be offered sooner than they are. And I think injections sometimes are a bit of a barrier. And sometimes patients that really want an injection, when given the option of surgery in a balanced way of risks and benefits of the surgery, that they'll go for the surgery and probably do much better with that one-off intervention than continuing to have repeat appointments for injections.
Yeah. I'm going to make an assumption, but I presume this would get extra tricky when we have someone who's keen for it, but for every reason, whether their surgeons told them that the surgery won't be appropriate yet, or they don't want the surgery, and then they're pitching up to you for this injection that may not be suitable either. And I presume is that a case of, as you said, having to live with it until either it is the right time or they change their mind.
It's individual, that one, Ben, because I've got some patients who are maybe in their 80s, early 90s even. They might not want a knee replacement. They might be medically unsuitable for a knee
Yeah.
replacement. And they tell me they have a benefit of maybe 6, 9 months from each injection. And they tell me that that injection allows them to go to the bingo,
Yeah.
go to the community centre, do their shopping independently, do a bit of gardening. And the alternative for that individual might be tramadol, you know,
Yeah.
or other opioids or gabapentinoids that will give them so many other side effects. So in that instance, maybe I'm quite happy doing repeated injections to to give them that independence
Yeah.
when there isn't another viable option.
Yeah.
But maybe someone who's in their 50s that's got early arthritis of the knee hasn't really engaged in any other options at that point. I'd be really reluctant to give them a steroid injection, certainly reluctant to get them on a train of repeated injections. So
Yeah.
it depends. It's personalized care, I guess, isn't it? It depends on the person in front of
Yeah.
you.
Do you think you were mentioning about earlier, obviously, that back in, you said 2008 or around that time, the injections and the biomedical bit was considered the advanced part of being an APP.
Yeah,
Is there, as you said, the hardest conversation of telling them no when they want one? Is that the, it's not necessarily the treatment, is it? But it's the thing you're having to do. Is that
yeah,
almost the advanced but part of the job that wasn't talked about in a way?
yeah. It is. Advanced practice. Communication is advanced practice,
Yeah.
and sometimes our tier one or our physio colleagues have a patient in front of them that's maybe stamping the feet up and down saying, I don't want physio. I'm not going to do exercises. This isn't going to help me. I need an injection. And the physio refers them.
Yeah.
And I see that referral and I read the narrative and I think, I'm going to be in for a tough time here.
Yeah.
And by the end of the consult, often they're relaxed. They understand about the pros and cons of injections. And in most cases, they say, yeah, no, I don't think I need an injection. Yeah, I'm happy to go back to see the physio, do my rehab.
Yeah.
And I go, well, what is it? Is it the uniform? Is it the advanced practice title, the badge?
Yeah.
But I think the communication side of things is a massive part of it.
Yeah.
And I think that comes with time.
Yeah.
I was nowhere near as good at having these conversations about injections when I started injecting than I am now over years with experience.
Yeah.
Um, and I think that is one of our superpowers that does kind of define our advanced practice and should
Yeah.
be more of a central tenet of advanced practice than it is currently.
Yeah. Some most, people think about advanced being being able to order imaging, the injections, all
Yeah,
that bits. And they don't know about that these conversations that you have to have that you can, as you said, avoid or pass on when you're not at
yeah,
that level to someone else who has to.
yeah.
Um,
I mean, you could replace injections with scans,
yeah.
and over the passage of time, as you develop into advanced practice, you get better at having those conversations about when a
Yeah.
scan isn't appropriate.
Yeah.
Um, but it needs work. But more than anything, it just needs time,
Yeah.
mileage,
Yeah.
learning from your mistakes. And we all get it wrong,
Yeah.
but that's how we learn.
Yeah. Before we jump into your hardest conversation, are there anything else about communicating with steroid injections that you wanted to add that I've missed?
Um, the only other thing that's a bit quirky, and it's with patients that are really worried about the pain.
Okay.
They're a bit nervous, and they say, "Oh, I fainted before. Really don't like injections. I'm sorry if I scream the place down."
Yeah.
Oh, okay.
Mhm.
And it's something I learned from Monty Lyman book around pain,
Okay.
about the power of distraction.
Okay.
And I'm pretty sure it was in Monty Lyman's book that he says it's worth trying giving the patient something to think about, process at the point of you giving the injection. So I say to a patient, before I give you the injection, I know you're really nervous about it, so I'm going to give you something to think about. Take your mind off it. I'm going to ask you a question, a second or two before the needle goes in. Okay. So I don't tell them what's coming, but I just tell them I'm going to ask them a question. So I kind of pre warn them. So just a few seconds before I put the needle in, I'll say, so the question is, I'm going to ask for your answer after the injection. Would you rather own an underwater car or a flying carpet for the day? Patient starts to think. 2, 3 seconds later, the needle's gone in,
Yeah.
pressed on a plunger, withdrawn, put the cotton wool on, and we're done. So what have you decided then? And you can tell they're thinking about this underwater car or the flying carpet, what they do, where they go, um, and they'll either tell me what they prefer and why. And so, how was the pain? Oh, it was fine.
Mm.
And whether that was to do with my maybe gentle technique, or maybe it was to
Yeah.
do with the fact that they were distracted with something else that they were
Yeah.
thinking about, something novel, something interesting. And you could insert, in a second, I'm going to ask you to tell me about your favorite holiday and why. Whatever it might be, it doesn't have to be underwater cars.
Yeah.
But that for me, for some people, has been useful to distract them from the procedural pain.
Yeah.
Um, so that's something people might want to try.
Fine. I know whenever I have blood taken or other injections done, I always try and talk to the person. So I can
Yeah.
do that. I still feel it. Do you think if you actually have to try and process something, is that more distracting than just having the chat?
I guess both are a distraction.
Yeah.
I don't know whether one would be more effective than another, but I think the power of distraction is useful. So if you're an experienced injector, you can have that small talk, that general chat. As a new injector, you try to stop your handshaking. A lot of students come back on the course say, "Oh, how did the injection goes? Oh, I dropped the needle, I dropped the syringe, I was that nervous, and I pressed too hard, and the steroid squirted in my face and in the patient's face." So if you kind of relax and experience, it's probably easier to distract the patient than maybe when you first start.
Well, Nick, I ask everyone this, and you obviously knew this question was coming. Um, it doesn't have to be related to steroid injections. It can be whatever the scenario is. But what is the hardest clinical conversation you've had with someone or collection of people?
I guess from an injection point of view first, it's those patients that are not appropriate for a steroid injection that day because they may have had a live vaccine. And there are certain kind of instances where you can't offer a steroid so close to a live vaccine. And it's been unbeknown to me and the patient that that actually could interact and we couldn't proceed with the injection. And that's a particularly difficult conversation if the patient's waited several weeks for that appointment. They've been looking forward to it. It's the right treatment for the problem. The problem's having a big impact on their life, physically, emotionally, mentally. And they've built themselves up for this injection. And they've taken the day off work. They've got the partner to bring the car.
Yeah.
And I've got to tell them they can't have the injection because they had the COVID vaccine last week. And the look on their faces, it's awful because you really want to give them that injection. And it's really tricky to kind of to communicate that. And you've just got to do it in your most empathic way. You've got to demonstrate compassion,
Yeah.
but at the same time help them understand that the reasoning behind it, that you're not trying to be awkward. And I think if you can quite easily kind of display that emotion to the patient that you feel like you really want to give them this injection today as well.
Yeah.
Really sorry, we're going to have to rearrange it. And they go away sad, and I kind of think, oh, that's
Yeah.
sad. I've not, helped that person. Um, but that's probably the most tricky injection-related conversation. Um, and probably as an APP, it's our responsibility to request diagnostics, and something I really struggle with it, and I still struggle now, is those patients that come back with a normal scan.
Okay.
And for some patients, that's really reassuring. It's it probably kind of allays their fears of the worst case scenario, tumors, cancers, etc. And they go away really happy. But for some patients, it doesn't give them the validation
Mm.
that they were looking for. They were hoping they could have a label
Yeah.
because no one's given them a label. They were hoping it would lead to an intervention, a treatment, a pathway forward, and it doesn't. And often the question is, so what is it then? Or do I not need another scan, a different scan? and sometimes I'll try and kind of preempt what the scan may or commonly not show before. And there are certainly for MRI, there are kind of NHS England girth little leaflets now you can give patients about normal findings, pain not being related to scans, etc.
Oh, yeah,
And I give those out to patients as well to try and kind of preempt that normal scan.
yeah,
That doesn't mean your pain is any less real.
yeah,
But I still struggle with those conversations sometimes, taking the patient on that next step in their journey,
yeah,
which often is strategies to live well with the pain,
yeah.
you know, and that's tricky.
It is. Is in your experience and obviously now mileage of doing it, is anything you found that helps make that easier with the trying to help them understand with the, as you say, normal imaging or normal for their age imaging, where there's
Yeah,
nothing, no
I
targets.
think putting the hard yards in before in that consultation when you're requesting the scan,
Mm.
providing them with the leaflet that explains things, providing the Explain Pain in 5 minutes video on YouTube, or Lorimer's Tame the Beast is another one, using some of the flipping pain resources, that can be useful.
Yeah,
And then it's kind of referring back to that in your explanation, you know. It's kind of normalizing it, I guess, as well with the patient sometimes, and that, we see many patients that have terrible pain like yours, and their scans, like in this case, come back normal. So trying to kind of normalize it as well, they don't feel alone, um, offering that compassion that, I can understand this is still a real struggle for you, and we need to work together to find a way forward.
yeah,
We now know there are some avenues that are not going to be useful for us, like injections or surgery.
yeah,
And that's probably the only thing we close the door on at that point, if they have a normal scan. I'll try and emphasize, that the good news of, that nothing serious, and then kind of suggest there are some other options we could discuss now if you'd like to.
yeah.
And sometimes they'll say, no, I don't want to. I'll just go away and have a think about things.
Okay.
And that's maybe part of the grieving process,
Yeah, yeah, yeah,
and
yeah,
that's okay. And I'll try and kind of finish and say, well, I'll leave an open appointment for you. Give us a call. I'm more than happy to kind of have another chat on another day, when it's had a chance to kind of, think about it and filter through. And other times, patients are ready there and then to have those conversations about other options.
yeah.
But quite often, I find they then really need some time to have a think about things and
Mm.
process this, what seemingly is quite disappointing news for them.
Yeah,
And then at that point, I might say again, would it be useful for me to send some information about, you know, pain more generally to help you understand this situation?
yeah,
And they usually say yes. So then it might be I'll send them maybe some video links, some leaflets, again from Flipping Pain or Live Well with Pain type resources, and that I feel sometimes helps. And then ask them to, get in touch, give us a call. We can have a chat once you've had a think about this news and read some of the information, and we can come back together and plan something. Sometimes I'll say, would you like me to book something? So it's not a PIFU, sometimes it's a booking, and
yeah.
the patient will make that choice. But yeah, they don't seem to be getting too much easier, those tough conversations. And yeah, work to be done for me to really kind of, improve those. But I'd imagine they're quite tricky conversations for most APPs, when you get that normal scan.
Is that another tricky part of being the APP that you're going to see them, you may order the imaging, you're going to discuss the imaging result with them, but you're not going to see them again after that, probably. You're going to may refer them on or not anywhere at all, depending on what they decide. But
Yeah,
trying to, if someone comes to me in a pain service, they can come back not as many times as they like, but they can come back twice, 3 times. We can discuss it, and it takes time, and that's fine.
yeah,
But you've got one shot basically, and they're
yeah,
probably not going to take it all in.
no.
And is that another like kind of not known advanced part of being the APP?
Yeah, it is. It generally it's a one-stop shop in APP clinics. Your review appointments might be half the length of time, maybe 20 minutes to discuss the results. And if those results, like in this case, open a real can of worms for that person, 20 minutes is not a great length of time. Those are the ones that do go over.
Yeah.
And then it's signposting to your community pain services, your physio services.
Yeah.
And they then pick up the baton of having to build that therapeutic relationship to help that person take the steps forward. And sometimes you're in an APP role, you really feel like you'd want to stay with that person because you might have developed a good therapeutic alliance with them.
Yeah.
But often the constraints of the service models means that that's not always possible.
Yeah. Speaking of pain, and thank you for sharing those difficult conversations, by the way, because it's important that people know that even if you get these additional, skills and abilities as one progresses, the conversations get harder as well.
Yeah.
You're doing your PhD at the moment. You said you're 4 years in now.
Yeah, that's
Out
right.
of how many?
I'm hoping to be complete in the next 6 to 9 months.
Oh,
So I'm coming on the last stretch now. So there's a bit of light at the end
okay.
of the tunnel, which is giving me that extra motivation to get it over the line.
And I know we discussed this beforehand, but would you be able to just tell everyone else what it's on and what you're doing your PhD in?
Yeah, so it relates to flipping pain. So
Mm,
some of you might be familiar with flipping pain. It's a public health campaign aimed to help the public and healthcare professionals understand pain. You know, understand pain differently,
mm,
talk about pain differently, and treat pain ultimately differently.
mm,
And that public health approach to pain is something that is it's quite new. You know, as clinicians, we're used to treating people, you
mm,
know, downstream when they've fallen in the river and they're in a really bad way, and we've got to try and pull them out. Um, so Flipping Pain is a campaign that's really inspired by Pain Revolution from Australia and Lauren Mosley's kind of group that aims to kind of just realize that the public don't understand pain. There's so many myths and misconceptions, and that's a real barrier to when people do develop persistent pain. So light bulb, maybe we need to change the narrative around pain and our understanding of pain
mm,
before people get pain, or very early into when they get pain. And maybe we can kind of try and deal with pain so much better if people understand it, maybe even at school level.
yeah,
So the PhD focuses on aspects of the Flipping Pain campaign and a few components. One was an outreach tour in the county of Lincolnshire, where we did some evening seminars with the public in community spaces, some pop-up brain buses where we use kind of interactive experiential learning to help people understand the role of the brain and the link to
mm,
pain, using VR headsets, visual illusions, and the like, just making it fun. And most of Flipping Pain is around making something that would seem quite dry. Who'd come to an evening seminar about
mhm.
pain?
Yeah, exactly. Yeah.
But it's fun, it's interactive.
Mm,
So there was the evaluation of pain beliefs before engaging in that activity in Lincolnshire, and then afterwards with a longitudinal follow-up with some qualitative interviews of what people thought about it, what resonated with them, what myths were bust. You
yeah.
know, then there are aspects of the campaign evaluated in the PhD related to some of the online events. So some of the healthcare professional events, how effective was it at shifting beliefs around pain in healthcare? Because healthcare professionals have got to go some way as well as the public.
Yeah. Yeah.
And then also a lot of some evaluation around online events for people in the community, most with pain, because people with pain tend to turn up to these events. It's showing some promising results. So it is something that I think with the right kind of funding and priority from public health funders would create a space for clinicians with an interest in pain
Yeah.
to do something really exciting, really different, um, to try and kind of address the challenge of persistent pain.
I know you said you've got about 6 to 9 months to go on the
Yeah.
PhD, but from what you've done so far, knowing how services are set up and your experiences, um, from what you've done, what would you change if I was to give you the keys to the pain management castle, so to speak? What would
Mhm.
you, from what you've learned, what would you change?
Potentially education at
Okay.
school level. I
Mhm.
think that would be useful because it seems that most individuals' pain memories or pain learning points come at school level, particularly in the teenage years. That
Mm,
that would be one. Um, healthcare professional understanding of pain would be another one. And that's huge. That's broad. It's not just physio, it's GPs. Now it's social prescribers, it's physician associates, it's paramedics. Everyone that's got first contact will come into contact with someone in that GP practice with pain.
Mm.
And that's a big challenge. And also even kind of patients that present with an ankle sprain, which very rarely people will have a discussion around pain when they have an ankle sprain.
Mm.
Physios would address that very biomedically
Yeah.
because there's that perception of, well, this is an ankle sprain. It's not like back pain. My approach needs to be different. But actually, there are certain elements within that sprained ankle that just dropping some seeds around helping them understand pain
Mm.
might help prevent that ankle sprain becoming a persistent pain state.
Mm. Mm. Yeah.
And I think that's something that maybe we need to consider doing a bit differently as well.
And, well, and you've got 9 months to go, and then be Dr. Nick at the end.
Yes, it will be. Yeah, I guess that's the only thing that will change. Um, but it was just one of those things. I'm always one to look at the next challenge, and then what's the next challenge. But after this challenge, I'm ready for a no challenge period. That would be quite nice. Watch some series on Netflix, and just do things that I don't get the time to do.
Before we finish, we're going to talk about NEMS,
Yeah,
which remind me what NEMS stands for.
Northeast Musculoskeletal Society.
Thought so. Which is now, you said, 8 years going.
Yeah,
The conference every year around
yeah,
autumn time.
that's
Uh,
right. Yeah,
I presume somewhere always in the northeast.
it is. Yeah, yeah, usually Newcastle upon Tyne. Yeah.
And anyone can go. You don't just have to be from the northeast of the UK.
Yeah, we get people from Scotland, the Northwest, the Midlands, Yorkshire, occasionally from further down south, but usually the Northeast.
Uh, and any online stuff as well, or just
Yeah, so we do. We're now kind of off a hybrid CPD. So NEMS was set up about 8 years ago. Myself and Rob Tyre, one of your previous guests, we sat down in our local pub and said, you know what? There's never any CPD in the northeast of England. All the courses are in London, in Manchester, in Liverpool. That's not right.
Mm.
Why don't we do something about it? Why don't we set up a CPD event, a group, a company, whatever? Yeah, let's do that. So the idea kind of spurned from that, and we said, well, let's do an evening lecture. We'll go to the local uni and say, sorry, we've got no budget. Can we have one of your lecture halls for an evening? Oh, go on then. So we got a room, we got a speaker, we filled it with 150 people.
Wow.
And we just kind of word of mouth, sent some emails around local trusts, private practices, free CPD, come along. Everyone was, yeah, it's great because we don't get any other CPD in the Northeast. We've got to travel everywhere. And then there was this huge appetite. So then we said, well, let's set ourselves up and we'll get some sponsorship and some local private hospitals will come with a pop-up stand and give us £200. And then before you know it, we're having a constitution where we developed a commitment to do quarterly free CPD on an evening. We do cadaver evenings at the local university for anatomy.
Mm.
We have a research fund where people can apply for small scale projects. And we do face-to-face workshops periodically for more skills-based CPD. And we have an annual conference. And at the annual conference, we bring in the biggest and the best names across the country. And we've had overseas speakers as well. And now people love that because they don't have to go to London to hear Joe Gibson speak.
Mm.
They don't have to go to Manchester to listen to Jeremy Lewis. We invite them to the Northeast and they come because we look after them. We give them a good time. We take them out for a meal, and we've got some money now to pay them.
Yeah.
So NEMS is something in the Northeast people I think are really proud of. Certainly me and Rob are proud of founding it those 8 years ago. We take more of a back seat now. There's a committee that's elected. They change roles every 2 or 3 years, and they're going great guns in continuing the momentum of NEMS to ultimately just raise standards in the region. And it's something we're really proud of.
If people, not just the UK, but people across the world listen to this, if someone was in a more remote area that you said wasn't getting as many uh speakers coming through, but wanted to try what you and Rob tried and set it up, what would you advise?
get in touch with me and Rob on social media.
Yeah.
But let's have a chat about it. And I've done this a few times, and people have noted, now that's interesting. What do you do? I'm keen to do it. And we did the same at a group in Manchester. Just to learn from people that have done it, get a bit of momentum, grow your networks locally around places that employ lots of physios, and say, got some free CPD, got a good topic, come along. There's the link. And since COVID, it's so much more easier. People don't have to get out of the pajamas anymore, go and park, put the money in the meter. So, it can be done. It's a little bit more tricky now because there's so much free and available online.
Mm.
So that's the one thing since COVID, NEMS has had to pivot to make it worthwhile for people to, you know, put on some clothes out of the pajamas and actually leave the house to go do some CPD.
Yeah.
But I think we lose a lot of the added value of face-to-face CPD if we do too much online. It is a personal feeling.
Yeah.
I don't think we concentrate. I don't think adults learn as effectively online because we're distracted. We
Yeah.
do the ironing, we put the washing in, we
Yeah.
do the washing up, we put the kids to bed, all while listening to a CPD webinar,
Yeah.
and it's not going in.
Mm.
But if you're in the room, you've got that full attention.
Yeah.
You're engaged in the topic so much more.
Absolutely. So if people want to ask you more about that, they can find you on Twitter
Yeah,
and LinkedIn.
yeah,
The course, your injection course, you said is a 20 credit master's module, is that right?
that's right. Yeah,
At Teeside.
yeah,
Um, and people can come from anywhere for that, I presume. Don't have to
yeah.
relocate to
It's
that.
our satellite campus in Darlington, and Darlington's on the train line. So if you lived in London, you could be in the classroom at Darlington in 3 hours. So if you come from Leeds, it's on a train line as well. So it's really accessible. So yeah, it runs twice a year, April and October. So if you go to Teeside University, MSK Injection Therapy, you'll find that course there.
Is there still the update as well?
Yeah, so independent of Teesside University, I also run an update for injectors who want a refresh of the evidence, the guidelines, chat about hot topics, do some case studies. A really interactive half-day update, and that runs probably twice a year. So I'll have some dates probably coming up January, early February time. So keep an eye on my socials, LinkedIn and Twitter for updates and links to book that.
And people can find, if I've got this right, NEMS on Twitter and Instagram as well.
That's right. Yeah, Twitter, Instagram, and LinkedIn. So Twitter is NEMSOC16.
Oh. That the first year it started?
Absolutely. Yeah.
Oh, and I'll put it all in the description as well, so people don't have to try and remember. They can just click on the description for this.
Great.
Uh, anything else to plug or you would like to promote that I've forgotten?
No, I think that's it. I think we're good, Ben.
And I can only thank you again for doing this and for speaking to everyone about this. Um, and like I say, all the website for your course we'll put on the description. The social media we'll put on the description.
Yeah.
Anything I've missed or you want to say before we let the people go?
No, I think we've covered quite a few bases there.
Yeah.
And it's nice to kind of frame the focus on the communication
Yeah.
as opposed to the detailed clinical reasoning about it.
Yeah.
Because I think that is equally important, if not more important, than the practicalities of injections and some of the clinical reasoning. So,
And,
yeah, thanks for the interview, Ben. Really appreciate the invite.
well, thank you.